We also have another study, which is a multi-centered randomized crossover trial. And this diagram over here on the right, I know that the writing is really, really small, but basically it's just a schematic to show how patients were allocated. This is called the Pessaries study. And I'm not going to try to tell you what that acronym stands for. I'm very bad at that, but there is an acronym, as there is for almost all urogynecology network studies, that fits Pessary very well. Again, it was a randomized, multi-centered crossover trial comparing ring with support to Gellhorn Pessary for prolapse. And women were essentially evaluated after 3 months with each Pessary. And the outcomes were essentially quality of life assessments with the PFDI, PFIQ, and visual analog scale. They looked at statistical significance, but they also made the criteria for satisfaction just a little bit more stringent by ascribing a clinical significance as well. And the clinical significance implied a difference of half of the standard deviation of baseline scores. So the results were essentially that both Pessaries provided statistically and clinically significant improvement in prolapse symptoms and the PFDI scores and subscores. There were no statistically significant or clinically significant differences between the two Pessaries. And in terms of patient satisfaction, this was a dichotomized outcome using VAS score, and it was dichotomized to the score of 8 or higher or less than 8. And essentially, women were equally satisfied at a rate of 60 to 70% with the ring and the Gellhorn. So what do we have to worry about when we're using Pessary? Now, I know that a lot of you who have rotated on urogynecology have heard us talk about the importance of Pessary maintenance. So the reason for this is that leaving a Pessary in place is, essentially leaving a foreign body in an epithelialized environment, and that can lead to scar formation or incarceration in which the Pessary really can't be removed. But it also can lead to pressure necrosis, and that's probably a little bit more common. And that is essentially the process by which the Pessary pushes enough pressure on the wall of the vagina to prevent good vascularization, and that leads to tissue breakdown. And in its worst form can lead to fistulization. And this particular picture actually comes from a case report out of the Cleveland Clinic in which a Gellhorn Pessary had been left in for several years. The Pessary had become incarcerated, which means that the disc portion of the Gellhorn Pessary was above a sort of a thin ring of scar tissue. And that scar tissue then required lysing in the operating room, and then the Pessary was able to be removed. And this is a follow-up examination of the patient. And what you're seeing here is a vesicovaginal fistula. These Alice clamps are on the vagina, but sort of at the junction of the vagina with the bladder epithelium. So you can sort of see that removing the Pessary allows the team to sort of evaluate the fistula, but that's going to be another surgery for this patient. I myself did a study in my fellowship on another sort of complaint that patients have with Pessaries. Again, because this is a foreign body in an epithelialized environment, a lot of women complain of some foreign body type responses, including discharge. And so I did a study in my fellowship to try to figure out if the discharge that women are experiencing is a sign of an infection or something else. Knowing that the vagina is sort of a polymicrobial environment, I was curious about the impact of this foreign body. So I teamed up with an infectious disease specialist who worked for a short time in my residency, but went back to Magee Women's Hospital where he did his ID fellowship in women's health. And we looked at postmenopausal women only who were not on any exogenous estrogen. And we looked at two different groups: women who had been wearing pessaries for at least 3 months, and they were considered established pessary patients who probably had already undergone whatever microbiologic changes they were going to undergo, and they were sampled once. And then women who were new to wearing a pessaries, and we evaluated them multiple times at baseline, and then 2 weeks into pessary use, 3 months, and then 6 months in. And we looked at multiple different outcomes, including microscopy, gram stain, culture, which was really just a qualitative culture, and not the sort of more modern culture techniques that we have now. These were standard kind of commercial lab cultures, and patient symptoms. And what we found is that if you look at women who are bothered by pessary discharge and women who are not bothered by pessary discharge in the established group, and you look at women who are brand new to pessary, they all have essentially the same distribution of bacteria in the vagina. There's sort of a really no difference in terms of the major species. And so that argues a little bit against the idea of an infection in the vagina. After 6 months of use, there are some things that change over time, including white blood cells and parabasal cells. Parabasal cells are immature cells that come from the basal layer of the vaginal lining, and larger amounts of parabasal cells tends to indicate inflammation. Now, one other thing that we commented on with this study is that it's difficult to use the term bacterial vaginosis in these patients because, in this group of patients who were all postmenopausal, all hypoestrogenic, those women already meet several of Ansell's and Nugent's criteria for bacterial vaginosis. And so you wouldn't want to, that it's not really an appropriate way of classifying these women, because the term bacterial vaginosis really is more about describing a change in microenvironment from the normal in a reproductive aged woman, and not in a woman who already has a pH that's high, already has a dearth of lactobacillus, et cetera.